Good morning. This is Emily Henderson, Stacy Allen, Melanie Landrum, and Claire Arendt with the Kentucky Hospital Association. We are delighted that you have chosen to attend Kentucky SOS or Kentucky Statewide Opioid Stewardship's webinar entitled Development and Implementation of a Multimodal Analgesic Order Set. The lines are muted. However, you can unmute your phone at the conclusion of the presentation to ask for questions. You may also utilize the chat box for questions during the presentation. And as always, the presentation slides and webinar recording will be posted on the Kentucky SOS website for your reference or to share with colleagues about a week or so after today's webinar. I will also email all Kentucky SOS project leads, the slides and recordings once they are posted on the Kentucky SOS website. So, welcome to today's Kentucky SOS webinar entitled Development and Implementation of a Multimodal Analgesic Order Set. This webinar is the second in a series of 4 monthly webinars, which will conclude in July, focusing on the following topics: physical therapy as an alternative to opioids, inpatient multimodal analgesic order sets, perioperative opioid stewardship and changing the culture, and proper prescription disposal and education. Kentucky SOS collaborated with Baptist Health clinicians for this webinar series, and it exemplifies best practices for opioid stewardship programs, a true multidisciplinary approach representing pharmacy, physical therapy, nursing, and medicine disciplines. Today, I have the honor of introducing presenter Dr. Doug Euler. Dr. Euler is an assistant professor in the Department of Pharmacy Practice and Science at the University of Kentucky College of Pharmacy. He serves as director of the Office of Opioid Safety at the University of Kentucky, where he leads the institution's opioid stewardship program, including development, implementation, and evaluation of strategies to improve safe opioid use within the health system. He has collaborated with the Kentucky Hospital Association, CASPR, and numerous other and local entities to improve opioid use throughout Kentucky. Additionally, he is a co-investigator for the Healing Community Study funded by the National Institute on Drug Abuse, where he coordinates naloxone distribution efforts. His work in opioid stewardship has been featured in Drug and Alcohol Dependence, the Journal of the American Dental Association, and the American Journal of Health System Pharmacy, among others. Dr. Euler graduated from the University of Kentucky College of Pharmacy in 2010, where he then completed a pharmacy practice residency, a critical care specialty residency, and a fellowship in academia. Dr. Euler also sits on the Kentucky SOS Advisory Committee, and we are grateful for his leadership and time. So Kentucky SOS welcomes Dr. Doug Euler.
Thanks, Emily. And thank you everybody for attending. My name is Doug Euler. I'm a pharmacist by training, and I've done a lot of stuff with UK Healthcare for their opioid stewardship program. So what I'm going to talk about here is some work actually we did a few years ago to put together this multimodal analgesic order set, really focused on opioid use in the inpatient setting and just kind of looking from a wider scale than really just perioperative for like specific procedures or doing something specific in the PACU or in the ED or something like that. Just trying to get kind of a wider net. So I'll kind of go through what we did there, and that was actually used to, I think, to kind of, some of the stuff that was done at Baptist was modeled a little bit after or off of that, and what they did in Epic, and then we can talk a little bit maybe towards the end about kind of where this is going at UK as we change the MRs and stuff as well. But anyway, go ahead and get started here. All right, so I have nothing, no financial disclosures. Again, the objective here is going to be to describe the components and design of this order set. And again, it was really focused on reducing inpatient opioid use. So we'll kind of go through a little of some basic background stuff, spend a decent amount of time talking about what went into that order set and why. And then we'll go through exactly what it is, the evidence behind kind of order sets and stuff like that in general, and in terms of what we saw. So for some general backgrounds, if you've seen a talk on opioids, you've seen a slide like this, or maybe this specific slide, looking at the different phases, if you will, of the opioid crisis, where more and more overdoses. Again, now this is driven by largely by synthetic opioids. But when you look at opioids that are misused, people that have an opioid use disorder, a lot of this is actually still related to prescription drugs or starts with prescription drugs. So again, for a long time, overdoses were driven by prescriptions. Now that's changed with very highly potent illicit drugs available. But there are still several individuals that have an opioid use disorder, really initiated within, or that opioid use being initiated from the health systems. So this is, again, a little bit older data, but kind of one of the main studies that's still referenced about how people transition into illicit drug use. Most individuals start with prescription opioids, and then when you look at where they get those prescription opioids, this is I think this specific one is from 2018 or 19 from SAMHSA, but they kind of reproduce this year in, year out, and these numbers barely fluctuate, if at all, of kind of the source of those misused opioids. So really what I draw your attention to are the two big boxes here of these are drugs that come from the health systems or the healthcare system as a whole. It's not diverted, it's not manipulating, stuff like that. They get a prescription from one doctor, and that's all that they always see the same doctor all the time, or they get it a friend, relative, somebody for free that had leftover that they got from a doctor, and again, isn't stealing this, isn't selling it, or something. But then moving to inpatient opioid use. So this was a paper that was published a couple of years ago, looking at over 90,000 inpatients in their opioid administration within the inpatient setting, and then how that actually translated into long-term opioid use. So long-term opioid use being at 3 months and then a year. And this is really one of the first studies that suggested that kind of the extent, if you will, of that opioid exposure. So whether that was the proportion of days of opioid exposure in the hospital, so that first kind of series there, if you have more than half your days where you get an opioid in the hospital, you've got about a 1 percentage point increase in the likelihood of being on opioids at 3 months, and about a 2 percentage point increase in being on opioids a year later. Again, the closer it is to discharge, you see the same kind of thing. Not really much with where those opioids are initiated as far as the setting, and not too much with did you get other drugs with the opioids or not. It's really looking at did you get opioids in the hospital. So this was something that was used to again kind of reiterate the importance of trying to reduce unnecessary opioid use specifically, and not really just always adding other things on top of it, but doing it intentionally to try to reduce opioid use. There have been several other initiatives, and these kind of things are available. I mean, there have been webinars about these before through this program. This stuff is available, or at least linked, I think, within the SOS website. And we talk about it in standards and these kind of things as well. But looking at post-operative opioid use, so Michigan Open is a large group, obviously out of Michigan's Opioid Prescribing Engagement Network. But what they have done is put together guideline or guidance for essentially equivalents of oxycodone 5 milligram pills that somebody should get after specific procedures, and they link this to sometimes it's published studies, sometimes it's their internal stuff that they've done, kind of looking at how many pills people use and medians and quartiles and that kind of thing. But again, this is really specifically targeted for if you have somebody coming in a thyroid procedure or something, but this is, you can put a protocol in place. So we've kind of done those things in general. We put those standards and guidance and stuff available through the statewide opioid stewardship program. But again, what we were trying to do with this order set was look at that wider scale, and all those, a lot of times medicine patients or something like that come in not really explicitly for one procedure or one specific injury, acute event, but look at the entirety of that study across different settings. Also, ERAS protocols, again, that have looked specifically at perioperative opioid use. This one's a few years old. I'm going to actually, as we go through the evidence for the components of what's in the order set, we'll probably pick on the specific pieces of what they put fit in here. But examples of the others, this was for I think we have breast reconstruction. They've done them for probably 25 other procedures or so. Of this is what people should get. Here's how you kind of all bundle it together and look at the adherence to all the components of there's analgesia, but then there's also nutrition and mobility and such. So we look at the specific components. What we put in this order set was, so we looked at a lot of the other pharmacologic analgesics. We included opioids as part of it, understanding that that's kind of part of this comprehensive analgesic strategy. There's non-pharmacologic stuff in there as well. I'm not really going to talk about non-pharmacologic stuff, not because it's not evidence-based or not valuable. We included some of that in our order set of aromatherapy and temperature therapy and those kind of things. We've talked about PT and stuff before, but as a pharmacist, I figure my time is probably best talking about the pharmaceuticals that are part of this order set. So we talk about pharmacologic analgesia, right? And all the times that I talk about it or how I think about it, I try to break this down into, you've got acetaminophen and NSAIDs, and we try to do this in the order set as well, to kind of build around those. So not really think of those as here's other adjuvants and kind of put all these adjuvants together, and really you're going to add adjuvants to opioids. Because that's not always really the goal, right? So we can kind of reframe where we start from and say, well, we'll start with Tylenol and ibuprofen or Tylenol and NSAIDs, and we can add other things to it. Opioids, maybe some adjuvants that could be part of it. Opioids usually considered kind of their own category, and that's fine. But then you have all of the other adjuvants. So I would separate out acetaminophen and NSAIDs from those. We'll talk about a decent amount of these, not the ones with the asterisk at the bottom, but NMDA antagonists like ketamine, SNRIs, TCAs, anticonvulsants as helpful or not, as those may be in an inpatient setting, chronic pain, outpatient, neuropathic pain can be really valuable. Not quite so much in that short time period inpatient. We'll talk about that. Muscle relaxers and topicals as well. And there's some others that have really kind of nuanced areas where they may be beneficial, probably not in this kind of big scope of general practitioner managing general pain, if you will. So antipsychotics, haloperidol and migraines and that sort of thing. Benzodiazepines, cannabinoids. Not really going to discuss those much, and that's not part of our order setting. The other thing that I always try to include is this graph here, and what this does is it compared a few different contra reviews that were done, several years ago now, but we kind of pulled them all together and looked at the number needed to treat for one person to get 50% pain relief. This was like post-operative after same day outpatient surgeries. So 50% pain relief being your numeric score goes from an 8 to a 4, 4 to a 2, something like that. So the number needed to treat with 15 milligrams of oxycodone was 4.5. If you add some acetaminophen to it, you can reduce the dose of oxycodone. It works better. That number needed to treat goes down to about 3, which is the same as an over-the-counter dose of naproxen, and or a reasonable dose of naproxen. And then the most effective combination here is actually low dose Tylenol 90-12. So I bring this up to say, again, reframing kind of what that base is, if you will, and kind of what you're building off of on that foundation of thinking about acetaminophen, NSAIDs, and adding other things on top of that. And that just because these are over-the-counter drugs doesn't mean that they're not real analgesics or something that have a role in the patient setting. As far as dosing of acetaminophen, this is another thing that comes up a decent amount. Is what's the right dose to use? Typically, in otherwise healthy younger folks, younger being probably 65 and under, say 1,000 milligrams every 6 hours. You can start to phase that down as people get older to 1,000 milligrams every 8, 500 every 6. So you get 2 to 3 grams as your total daily dose instead of that 4 grams. But the limited evidence that's out there suggests that maybe 1,000 milligrams works a little bit better than lower doses of 600, 650, or there's a little bit of other stuff in dentistry with 500. So this was one study that compared, or a meta-analysis here that compared about 40, 50 studies of different doses You can see there's about 5,000 patients here found. The number needed treatment was a little bit lower, 3.5 versus 4.5 for that 50% pain relief for the higher dose. So folks that can tolerate it, it's probably better to do a higher dose. When you combine this with ibuprofen, maybe you can get away with lower doses and that sort of thing as well, and it seems to work okay. But the limited evidence that's out there suggests maybe higher doses is better. Again, in people that are at risk for liver injuries, you're obviously going to drop that some. Elderly, pre-existing liver disease, not an absolute contraindication, but use lower or substantial lower doses. Alcohol use, malnutrition. I spent a little bit of time talking about NSAIDs because I imagine, I mentioned building up off of NSAIDs and Tylenol as kind of a base or a foundation. A lot of people probably thought, well, NSAIDs have all these side effects and everything else. So I'm going to spend a little bit of time talking about those. So NSAIDs, they're a heterogeneous drug class. I think probably across the board, the analgesic effects are likely about the same or at least similar between ibuprofen and meloxicam, diclofenac, and et different NSAIDs. They should be considered first line with or without acetaminophen. And what you do is you see dose-dependent toxicities here. Most commonly, the serious toxicities are going to be GI-related, gastritis, bleeding, potentially perforations. We'll talk about how often this happens in a couple slides. And then there's others: acute kidney injuries, liver injuries, bleeding, heart failure, reproductive outcomes and things as well. But those others are substantially less likely to occur. And we'll talk about some of the other more common ones: kidney injury, liver injury, and some cardiovascular outcomes as well. So trying to kind of quantify the actual risk of these major adverse reactions. So we talked about upper GI bleeds, for example. So in the baseline population, it's about 1 per every 1,000 person years. So that means in a given year, 1 in every 1,000 people could be expected to have some kind of upper GI bleed. However, as that age goes up, so over 85 or so, that increases quite a bit. So in females, that goes from about 1 per 1,000 person years to about 5 per 1,000 person years, and in males, it's about 8 per 1,000 person year. If you've had ulcers before, then that is about a 10-fold increase in risk. So instead of 1 per every 1,000 person years, it's 1 per every 100 person years. And use of an NSAID is about a 4-fold increase in risk. So about 4 per every 1,000 person years. So if you treated 1,000 people with an NSAID for a full year, you could expect 4 of them to develop some kind of upper GI bleed. Just trying to quantify that risk with, age, other risk factors, and that kind of thing as well. Risk for acute kidney injuries is about, again, baseline maybe 2 per 100,000 person years, and NSAIDs double that about 2 per 100,000, or sorry, 4 per 100,000 person years, doubling that risk. And then an acute liver injury, again, similar baseline, similar increase in risk with acute liver injury as well. So that risk of upper GI bleeds is much more common. The other thing I would note about this is that there are this is a much shorter time frame, right? We don't have people that are hospitalized for an entire year. Obviously, now maybe there's there's other changes in people that are prolonged NPO or something like that, that it could modify that risk in some form or fashion. But that risk is still relatively low, and this is dose dependent as well. And that's what the graphs on the right of the slide starts to show some too. Is that at lower doses, and the number dose there is kind of what's considered that cutoff. You can see what that risk is. So it's drug dependent to some degree, but also dose dependent as well. The last thing is it's dependent on the duration that an individual is on that given drug. So we look at GI adverse reactions, comparing kind of the more common NSAIDs. So what this is comparing is ibuprofen, naproxen, diclofenac, and COX-2 selective drugs like celecoxib. So diclofenac being a little more COX-2 selective than some of the others. So these kind of non-selective NSAIDs like ibuprofen and naproxen seem to have a little bit more risk than the others. So you may consider using something like celecoxib or something that's a higher risk. Now the coxibs, and I'll talk about this a little on the next slide too, the coxibs don't really seem to mitigate that cardiovascular risk. Certainly don't seem to increase it, but that risk seems to be similar across different NSAIDs. Really the big variation is in those upper GI ones. The table on the bottom of the slide talks about that duration dependent effect. So in that first 14 days or so, maybe you have about a 3, a relative risk of 3 or so compared to baseline not being on the drug versus this is about 5.4. So I said before, if you kind of average that, it ends up being about a 4-fold increase in risk. Maybe in the first little bit of time, it's a little bit lower than that. As you're on this for longer and longer, it's a little bit higher. And this varies from study to study as well. But the point that I'm trying to get at with this is the longer you're on the drug, the higher the dose, especially if you're on specific ones, maybe have a little higher risk than you expect that risk to go up. Last thing to talk about NSAID safety. So this is from the Precision study. This was published in the New England Journal several years ago, really looking at cardiovascular safety was one of the main things they wanted to look at with NSAIDs and COX-2 specific or COX-2 selective NSAIDs. So that's what they wanted to look at the time. Really no real difference. That's the graph on the far left. No statistically significant differences in major cardiovascular events between the drugs. Gastrointestinal events, you do see lower risk with celecoxib, which is the green line there. And then renal events, not as many to be able to tell, but you do see perhaps a statistically significant difference between celecoxib and ibuprofen. Maybe celecoxib is a little bit lower risk. But again, the take-home point about risk is that GI. It's GI risks that are dose-dependent and duration-dependent too. When you look at dosing of NSAIDs, there have been a few studies that have looked at this. I like these 2 specific ones that came from actually the same group looking at single dose NSAIDs in the emergency department. The picture on the left is actually their second study, but it was ibuprofen dosing. The blue being 400 milligrams, green 600, red 800. Look at their pain score baseline and the pain score an hour later. And what you can see is that there's really no difference between the drugs. So we know that the adverse events are dose dependent, and it doesn't seem like increasing the dose past 400 milligrams increases the analgesic efficacy. Really no reason to pick more than 400 milligrams. And all of our order sets and kind of default ordering and those sort of things for ibuprofen, we've just defaulted to 400 milligrams. And then you see the same thing with ketorolac. So 10, 15, and 30 milligrams of ketorolac. Looking at baseline through 2 hours later at several different time periods. No statistically significant differences between pain scores at each of those times. So we default to 15 milligrams here just because of the logistics of it being 30 milligrams per 2 mLs. So it's easier to drop 1 ml than 0.67. But lower doses shine away from the 30 milligram ketorolac. So the lowest effective dose of these drugs is the other thing. We'll talk about the rest of these a little bit quicker, I think. Considering ketamine, this isn't something that we put into that order set. We kind of tweaked things later and maybe considered it for some opioid tolerant patients, procedural, that sort of thing. The important things to get from ketamine, though, are really staying on. So if you look at the picture here, this is kind of the range of effects, the range of dosing that you would expect from ketamine. Staying on the left side, this kind of dark blue, blackish color that's the analgesic dosing. So up to 0.3 milligrams per kilo, ideal body weight, cap it out at 30 milligrams. This can be given slow IV push by a nurse. It doesn't have to be given. It's not anesthesia or anesthetic dosing. There's a lot of contraindications to ketamine. Unclear how much these really apply to this really low dose ketamine, as most of them come from looking at whether it's intubation dosing of ketamine or things like conscious sedation or using this as a sedative. So we'll talk about some of those contraindications and relative contraindications, but when we're using this lower dose, it's unclear how applicable all those are. Times to consider this is really looking at maybe it's acute one time like procedural pain, or looking at as an adjuvant in people that are opioid tolerant at the baseline. Some of those contraindications that you consider with ketamine, obviously cardiovascular. So if you have, this can raise blood pressure, it can raise intracranial pressure, it can raise intraocular pressure. Again, the effect of these lower doses, not quite as clear as higher doses like the LSI. Active psychosis, hepatic disease, as we talk about antidepressants and anticonvulsants, I include these. We have them in our order set. The caveat here, though, is that you think about antidepressants and say, well, these are going to take a month or more to start working for management of depression. It's similar for management of pain. So, if you have patients that you'd expect this is some kind of chronic neuropathic pain or something that maybe was uncovered during a hospitalization, maybe that's a reasonable time to consider an antidepressant. However, just like a lot of times you can start these inpatient for management of depression, there's times where I suppose you could. It's similar here. Right? You wouldn't expect this to work in the time period of hospitalization for most folks. SNRIs is typically better tolerated than TCAs because they have that cleaner mechanism of action. We talk about SNRIs, it's usually duloxetine. Again, this is titrating weekly though, so you can already see how that doesn't align with a normal course of hospitalization for most folks. Those TCAs, amitriptyline, nortriptyline, again, titrating these up weekly, every couple of weeks. Those multiple mechanisms that they have may increase some of the efficacy. Maybe you can see effects a little bit faster, but it certainly increases the adverse reactions. So, cholinergic, sedation, those types of things are a little more prevalent with TCAs. Obviously, adding multiple CNS depressants, et cetera, cautions or considerations. I'll spend a little bit of time talking about gabapentinoids, and hopefully you guys will talk about this a little bit in the next one as well, where you talk about kind of perioperative and looking at these. But I think there's been a lot of enthusiasm about gabapentinoids, not necessarily based on strong evidence, just based on looking for opioid alternatives and that sort of thing. So we'll kind of talk about a little of the evidence behind gabapentinoids. I'm not really going to get into perioperative, just kind of anecdotally, that evidence isn't particularly convincing that they're opioid sparing. But as that really gets into specific procedures and when you do it and how much you give and all of that, it's kind of outside of the scope of here. But I think you can apply a lot of these general limitations to that same kind of perioperative gabapentin evidence base. So we look at the evidence for gabapentinoids. Pregabalin has a couple FDA labeled indications. So when we look at off-label evidence, that's really not applicable there. But even for common things like diabetic neuropathy, there's 5 studies that looked at this with gabapentin. 3 of them showed significant reduction in pain versus placebo. The other 2 didn't. But when you look across all of these other disease states, it's very rare that either the studies were conducted, like in spinal cord injury, fibromyalgia, phantom limb pain. So uncommon for the studies to be done in the first place, but if they are done, uncommon a lot of times for them to actually show any kind of significant reduction in pain versus placebo between either of the 2 drugs. And these are specific neuropathic conditions. The reason I talk about them a little bit separately is they are different. I think a lot of times they get lumped together. There's a little bit of concern with saying, well, pregabalin's labeled for this, it must have good evidence for it. Gabapentin is just a cheaper version of pregabalin, so we can just sub that one. Not necessarily. So pregabalin has a little bit higher binding affinity at that alpha-2 delta subunit. So the way that these drugs work, kind of binding there and modulated calcium influx. Pregabalin binds a little bit tighter and binds a little bit better. So maybe if gabapentin doesn't work, you could try pregabalin. Probably not the other way around though. So extrapolating that evidence becomes tricky too. And then you have intestinal absorption of gabapentin, which is really through one specific transporter. So you see dose-limited absorption, and that bioavailability goes down as the dose goes up. Now, importantly, as you slow down GI transit time, you can actually increase absorption. So you've got a couple mechanisms now for drug interactions with opioids that slow down your GI transit time. And you're now going to absorb more gabapentin, so you get multiple additive sedatives there. But pregabalin has several ways that it's absorbed, so you get consistently high bioavailability. So a couple nuanced differences between the two, but a caution against just extrapolating the evidence from one to the other. The other thing about gabapentin, I know it's a little bit busy slide, is this is a study that was published in New England Journal 13 years ago now, where they looked at industry-sponsored trials of gabapentin for off-label indications, typically painful, neuropathic painful indications. And what they did was essentially compare the a priori, like before the study started, endpoints that they reported they were going to, that they said they were going to report on, and compare those to what they actually reported on in the publication when it came out. So across these 12 studies, they had 21 primary endpoints that were originally said this is our primary endpoints. Of those 21 endpoints, only 11 of them actually made it as primary endpoints into the publication, and the other 10 were either not reported or reported as secondary endpoints. And then 12 new primary endpoints kind of showed up. Either they were secondary before and now moved to primary, or they weren't defined as endpoints and then showed up as primary endpoints in the publication. So, so that's the kind of diagram on the left. The figure on the right looks at the main thing I'll draw your attention to is the top part of this here. Looking at the red versus the blue lines. The red was p-values for the protocol-defined primary endpoint. So before, like when they said, here's the protocol for the study, we're going to do it. And the blue is the p-value for the primary endpoint of the publication. So what you can see is there are times you can look at the first and the third one there where something wasn't significant, but all of a sudden in the primary endpoint in the publication it is something significant. So not to say that anything happens one way or another, but it just raises a little bit of suspicion about gabapentin works for this. Well, that's not really what we set out to test whether it works for, and that's. The last thing about gabapentin that I'll bring up is that abuse liability. So the lifetime misuse prevalence in the general population is about 1%. In individuals with substance use disorder, it's about 20%. And in individuals that get a gabapentin prescription, it's about half. So ranges 40 to 65%. So if you say, well, we look at the risk associated with some of these other drugs, and then combine that or compare that to the risk associated with gabapentin, where 1 in 2, or up to 1 in 2, or even 2 in 3, maybe misusing the drug if you provide a prescription. Not commonly by itself, so usually with other CNS depressants, and actually it was detected in 2020 in 20% of drug overdose deaths in Kentucky, and that's been fairly consistent for a few years, which is why it's a scheduled, or one of the reasons it's a scheduled Title 5 substance in Kentucky a few years ago. Muscle relaxants, I'm not going to spend a lot of time talking about muscle relaxants though. In general, not first line, maybe they're adjuncts for acute low back pain. This could be something that could be considered, in an inpatient setting, because the duration of these is going to be pretty short. There's really not clear indications to have somebody on long-term muscle relaxers. Efficacy between them, not really. I mean, it's all about the same. They're all kind of equally not particularly efficacious. There's a few specific ones that you may want to avoid, and we can talk about that. Those are both controlled substances here in Kentucky. Benzodiazepines obviously federally, and then cyclobenzaprine aversion is actually starting to increase as well. So all of them probably have some abuse potential, especially if you combine these with other CNS depressants. I'm not going to go through this table. This study, the reference there is at the bottom, and most of what's in this table came from that study, or came from that review. And even though it's 14, 15 years old now, it's probably still the best review of muscle relaxant pharmacology, centrally acting muscle relaxant pharmacology. So the things I would point out here is that cyclobenzaprine, we can talk about diversion on the next slide. There is evidence that suggests that 5 milligrams and 10 milligrams work as well as each other. The 10 milligrams is just more sedating than the 5 milligrams. So we swapped our formulary product several years ago to just have 5 milligrams instead of 10 for the cyclobenzaprine. And the other thing I would draw your attention to is that both of the M drugs, metaxalone, methylpharmacol, seem to be maybe a little bit less sedating. You got to avoid all of these in elderly folks. All of them are sedating to some degree. But most of our order sets in general, including the one that we built, we'll talk about here, uses methylcarbamol, just because it seems like maybe it's a little bit less sedating than some of the others. So I mentioned diversion. So this was a study that was published a couple of years ago, looking at diversion rates of opioids and then other not controlled substances. So opioids are there in the red, the diversion rates from 2002 to 2017 of prescription opioids. Then the graph on the right with the blue, yellow, and green is cyclobenzaprine, the yellow is trazodone, and green is quetiapine. So you can see similar trends. Obviously, the y-axis is very different in 12 per 100,000 versus 0.08 per 100,000. So, but it's also a little bit trickier to detect diversion of not controlled substances. You can't look at PMPs or something like that. And then the other thing I would mention is there was a study published a few years ago that looked at actually associating any carisoprodol prescription with an increased risk of opioid overdose based on PDFP data. So again, not that there's never an indication for it, but probably need to have a fairly strong reason as to why carisoprodol is the best choice over other muscle relaxants. Is kind of what I would do that. All right, topical agents is the last thing I'll talk about as far as the pharmacology. Often these are specifically compounded or especially compounded, which is another way of saying there's not great evidence for most of them, because if there was, then some company probably would have bought it up and charged more for it. There is evidence for some, but it's kind of formulation specific, drug specific. So like topical NSAIDs seem like they maybe work for like acute sprains, strains, osteoarthritis. But it's really only specific formulations that have good evidence. Topical anesthetics like lidocaine, amyl creams, and that sort of thing are mixed evidence. Some things say it's not great, others say maybe, unclear. So like lidocaine patches and stuff like that, it's mixed. And there's really not good evidence for other things. So capsaicin, other NSAIDs, or salicylates, clonidine, herbal remedies. There's one capsaicin product that seems to work fine, but that's not something that you should be considering in patient. So most of those are really not great evidence. There's not really a lot of harm associated with them either, right? So when you do that kind of risk benefit, you can kind of think of these similar to like you might think of a lot of the non-pharmacologic stuff. There's maybe not great evidence that it's incredibly beneficial. Sometimes there is, but there's also not really evidence that it's harmful for anybody. Again, sometimes maybe, but so that risk benefit is kind of tilts a little bit. All right, so existing evidence for order sets. So there have been a few that have looked at order sets in the emergency department, looking at like the most common things that show up in general order sets in the emergency department. So, as you're thinking about putting stuff in an order set, now some of these may be really specific. So like lidocaine infusions or dicyclamine, kind of nuanced, haloperidol, kind of nuanced in ED. But some of these others may be drugs that you could potentially consider. As you're looking, these are things that show up most commonly. A little bit of the evidence behind actually implementing these order sets. So this is a study from Cesarean sections, kind of looking at what was in the old order set versus what's in the new order set. This was about 13,000 patients. What they found was that their inpatient opioid use decreased from about 2/3 of patients to a little bit less than half. After they implemented this order set, the number of patients reporting severe pain also decreased from a little bit over half to a little bit under half. And both of those were significant. What's in there? So basically alternating Tylenol and ibuprofen with some PRN, oxycodone specifically spelled out how they're going to get it. Other studies have shown that removing opioids altogether from order sets after like uncomplicated vaginal deliveries can decrease opioid prescriptions substantially by over half. Again, in an inpatient setting, not just looking at prescriptions. So this is a study looking at implementation of an order set after rib fractures. So what they kind of put in this was increased options, if you will, for non-opioids. So this is gabapentin and NSAIDs were kind of the main things that if you kind of read into it was what was in there. They put a little more comprehensive pain assessments though, so maybe moving away from just numeric pain scores to even something like the Defense and Veterans Scale. And then removing time numeric drug scores to drug administration. So like for pain score greater than 8, give fentanyl or something like that. And there's some position papers and things from Society for Pain Management and Nursing, I believe, that's kind of taking a stance against tying these to pain scores. But what they found here was that opioid use wasn't dramatically different. Some of the non-pharmacologic or non-opioid drugs, use of those increased. IV opioid administration actually was one of the main things that decreased here. Looking at this perioperatively as well, so another study of a smaller population, but a little more broad as far as the surgical population that you're kind of covering here. So this is GI, GU, INT surgeries, amputations. They found was their order set, which that is kind of complicated over there on the side, but their order set reduced opioid use, didn't increase pain scores clinically at least. So it was a statistically significant increase, but it was less than a point. But it did reduce opioid use by that. All right, so our experience at UK then. So the way that we used to do this before was, again, really focusing on short-acting or IV opioids, adding long-acting opioids on top of that, and then NSAIDs and acetaminophen. And then as you kind of taper things back off, the last thing on is the first thing that gets taken back off. So you end up with these short courses of opioids and kind of building your base on in the long run. So we took it and flipped it upside down, started in our trauma population. I'll talk about that in a second, but did non-steroidals and acetaminophen, incorporates some non-pharmacologic symptom-driven adjuvants and short-acting opioids on top, and then lean in the opposite. What we found was, this was several years ago now, but the percent of people who were discharged without an opioid. So the light blue is pre, the dark blue is post, and then we actually kind of followed up several years later and looked at kind of the sustainability piece of this, and that's what the green bars are. So the percent that were discharged without an opioid went from about 10 to 20%, and actually a few years later, this was just 1 month, so the population's not quite as big. It was up though, quite a bit. And then use of extended release products was down, and we completely eliminated those from practice after a few years. So what we had in our order set here was, so the way that this was built in, it wasn't, you could still order whatever you wanted a la carte. This was just the first thing that showed up when you went to order anything that was in the order set. So you went to order acetaminophen, it would take you here. You went to order, celecoxib, morphine, oxycodone, tramadol, any of that stuff. It would just take you here first, and that would just be kind of the first thing that shows up on the menu. But all the others were still over there. So getting in here, one of the main things we wanted to do was make something that wasn't incredibly cumbersome, that didn't have things embedded within it, that wasn't too many clicks or that sort of thing. But still tried to really remind folks, I guess, in real time of here's the other stuff that you can consider as well. So starting with some nursing orders for like non-pharmacologic therapy and that sort of thing. You start with non-opioids and use opioids for pain that's refractory and such. So having those kind of things be first, and then moving into those first-line pharmacologic analgesics that I talked about before, acetaminophen, NSAIDs, all of these defaulted to the doses that we had referenced before, but then to scheduled dosing as well, so not just doing a PI. Then second line agents for neuropathic pain, for muscle spasms, including those in there. And then some topical agents, and then kind of as you scroll a little bit down in here, you can get to some of the specific opioids. I've got the specific components of it here. We looked at non-pharmacologic analgesics I talked about before, acetaminophen, NSAIDs, and then here's those other adjuvants with the opioids pre-selected for as needed. And the way that these were, we kind of changed some of the as needed indications as well. So it wasn't just as needed for pain, but the default was as needed for pain that's unresponsive to non-opioids. And as a default, so you can modify it to whatever's appropriate for a given patient, but just again, kind of nudging and resetting the defaults. Same thing for like IV, PRN opioids of as needed for pain that's unresponsive to non-opioids and they can't take oral medications or something. So when we looked at this over the course of over about 9 months or so, this was, I think we put this out in middle of 2018. So over 9 months or so at the beginning of 2019, this was actually the most used order set in our institution during that time period. And it's primarily driven by some of the larger services at our institution. So kind of all the internal medicine, EGS, emergency general surgery, and the trauma surgery service, and then general surgery as well. So, the other thing that we'll do though is look at those services that used it the most, and then kind of compare opioid utilization. Did it actually change their opioid use, if you will? So if we compare kind of baseline, or our baseline was we looked at before, we kind of did a lot of these different interventions and things, but we look at our overall institution, so to kind of orient you to this here. The metrics that we'll talk about, so our average daily inpatient morphine equivalents, the percent of patients that are getting more than 90 morphine equivalents a day, and then the average daily pain score among those that are pain score reported. So we look overall across our institution. You can see that drops, the daily morphine equivalent drops by about 5. The number of people receiving high doses drops by about 2%, and the pain score stays effectively the same. But then we take those 3 services that are using this order set the most to try to tease out, because there's other interventions and things that are happening, provider education. There's obviously external things from whether it's House Bill 333 or CDC guidelines for us, but take those, maybe they're using this a little bit more. So internal medicine, you see similar reductions or similar in daily NMEs. You see a little bit more pronounced, about 3.5% drop in the patients that are getting high doses. Pain score went down a little bit more. Again, probably not clinically significant there. Trauma, a larger drop in their daily morphine equivalence use, a little bit larger drop in their patients that are getting high doses, a little bit larger drop, but again, effectively the same in pain scores. And then general surgery, again, you see kind of larger drops in average daily NME and the average pain score. It's almost a point there. So it does appear to some degree that you see a little bit more pronounced changes, not huge, not dramatic, but a little bit more pronounced changes among those that use the order set a little bit more. So kind of wrapping up here is, make sure we got time. So inpatient opioid use, this has been linked to long-term use after discharge, not quite as clear as like providing a prescription duration, and that sort of thing. Multimodal analgesia can reduce opioid use. It can improve pain control. I think some of those other studies showed that as well. And then when you design these order sets, you can maybe increase uptake of multimodal analgesia. Maybe this can decrease some of the opioid use as well. What we don't really have a good feel for is, well, if you implement this, does it actually implement the long-term outcome of the question of long-term opioid use or something like that? I think those would be things that may be a little bit tougher to tease out because of all the other variables. But those would be things to look at. And with that, I will take any kind of questions anybody has. I see one thing here. It's about the recording. So yeah, so I'm happy to take any questions. Thank you guys for your attention.
Thank you so much, Doug. This is Emily Henderson again. While you are thinking about your questions, feel free to unmute yourself and speak over the telephone line, or you can type in the chat box. But we'll do a little bit of housekeeping. Kentucky SOS is proud to offer continuing education again for pharmacy and nursing. And those portal instructions will be up on the screen shortly. However, the portal does not open until 12 noon, so do not try to get your CE until 12 noon because it will not work. Notice that the expiration date, the portal closes on June 11th at 11:59 p.m. Eastern Time. So please complete your evaluation and submit for continuing education for pharmacy and nursing by June 11th at 11:59 p.m. Also, CE has been approved for this webinar through the American APTA Kentucky Chapter, American Physical Therapy Association Kentucky Chapter for physical therapists, and that information will be on your screen also. And then, like all Kentucky SOS webinars, this slide set and recording will be posted on the Kentucky SOS website, and that website address is in your chat box. Doug, there is a question now for you in the chat box, please.
Sure. So we said, let's see. So we've seen an increased number of intubated patients during COVID. What's your recommendation for opioid stewardship for these patients? I mean, I think so. What we've looked at, and certainly looking at opioid use in the ICU, is there's kind of a still that push to move away from deep sedation and those kind of things. I mean, I think that the opioids are still valuable, still beneficial, still part of appropriate management of folks. I think those kind of general and I'm a little out of practice now. I'll be perfectly honest with. So my background was in trauma, worked in the ICU for several years. I haven't been in there in quite a few at this point, but I think a lot of it is, still using these drugs, and that's okay. I think navigating drug shortages and stuff can make things a little bit tougher, as well as, some may be available, may not. But, trying to use low effective doses, certainly trying to, if you can use lower doses for sedation, that's obviously beneficial. But then consciously trying to kind of taper down as those patients continue to improve is probably one of the bigger things. Not necessarily withholding opioids or anything else for management of intubated patients there, but I think consciously trying to taper those down. Certainly, one of our goals is, ideally by the time when you're out of the ICU, a lot of those things can start to go away. But certainly trying to avoid these being drugs that end up being continued out in the outpatient setting, I think would be one of the main take-home points there. There's another question about, have you seen successful results after orthopedic surgery with this order set? Some. So our ortho group used this to some degree. We actually did a little bit more. So ortho is one of the larger users of opioids at our institution, just because I think of the nature of the patients that they have, that it was a little bit different than some of the other surgical services. So especially as you look at hip and knee replacements and those kind of things, or a lot of the polytrauma patients. But what we did was we kind of worked specifically with them, kind of made a little bit more of a tailored order set, made a little bit more of some kind of tailored prescriptions and kind of built-in tapers and tailored things that they could provide prescriptions for folks when they leave. And actually went and evaluated that just I think it was just published last year, maybe or so. I'm happy to share it with Emily, and she can send it out if it's relevant. But looked at our trauma population and found that, we were able to kind of, with some of this education, with a little bit of stuff in built-in order set and multimodal protocol, substantially reduce the opioids that folks left with. But at the same time, this didn't result in more people coming back to clinic asking for more opioid prescriptions. It actually decreased long-term opioid use significantly. So that was really kind of, we took a lot of stuff from like the OTA guidelines and kind of implemented it there. So not really this specific order set, as this one ended up being more kind of the general population. That's a very good question. The other questions that folks sent out.
Okay, are there any other questions for Doug Euler at this time? If not, feel free to, if you think of something later, feel free to email myself. My email is in the chat box. Also, Stacy Allen, pharmacist, who's new to the Kentucky SOS program. Her email is in the chat box as well. If you are not on the Kentucky SOS distribution list and would like to be, please let me know. And thank you so much for attending today's Kentucky SOS webinar. Thank you so much, Dr. Euler, for your knowledge and time and expertise today. And everyone have a great day and great rest of the week. And thank you so much. And we look forward to working with you in the future.